Okay. Have you ever, like, just felt a flutter in your chest?
Yeah.
Like just a weird skip in your heartbeat?
Mm-hmm.
What if I told you that that skip wasn't random, but it was a sign of like a secret electrical pathway that your heart kind of decided to grow on its own?
Wow.
And what if I told you that like just a tiny squiggle on an EKG, like one you wouldn't even notice, could be like a huge clue to why your heart sometimes feels like it's racing out of control?
That's fascinating.
Well, get ready, because today we're going to like totally decode the secret language of your heart's rhythm.
Awesome. I'm excited.
Welcome back for another deep dive where we, take like really complex medical topics and we make them feel like you're just chatting with like a friend who really knows their stuff.
Yeah, exactly.
Today, you are taking us deep into the world of supraventricular tachycardias, or SVTs.
Oh, very cool.
But specifically, we're zeroing in on AV nodal reentrant tachycardia, that's AVNRT,
Okay.
and atrioventricular reciprocating tachycardia, or AVRT.
Right.
And you sent us some incredible educational materials for this. It's like having a cardiologist's like secret cheat sheet.
That's a great way to put it.
So what we're going to do is we're going to pull out like the biggest differences between these two, like the key clues that doctors look for to diagnose them,
Yes.
and like what's actually going wrong with the electricity in the heart that's causing these rapid heartbeats.
The electrical misfirings. Yeah.
Yeah, exactly. So by the time we're done, you're going to know the difference between AVNRT and AVRT.
I love it.
Like you could probably teach a class.
Hopefully not.
Before we get started, though, a huge thank you to London Heartbeats Z Academy in the UK
Absolutely.
for their incredible support. They make these resources available. And if you are interested in learning more, they have over 150 popular courses. So make sure to check them out and follow them on social media. That's Facebook, Instagram, and YouTube for free, regular updates. And to, make sure you don't miss out on more amazing discussions like this. Okay, let's jump right into AV nodal reentrant tachycardia, or AVNRT. So let's picture the person who typically experiences this. Who are we talking about?
So the information we have suggests that AVNRT is most common in adults who are, young to middle-aged.
Okay.
But interestingly, it tends to occur more frequently in females.
Absolutely.
Yeah. So if we were to imagine a typical individual with AVNRT, it would probably be a younger woman who is experiencing these episodes of, rapid heart rate.
Wow, interesting. So what's going on electrically in their heart when they're having an AVNRT episode? The material mentions something called like retrograde atrial activation.
Right.
What is that?
So that's a very important concept to understand. Normally, the electrical impulse in your heart, it starts in the upper chambers of the heart, the atria, and it travels down to the lower chambers, the ventricles.
Right.
But in AVNRT, during this rapid heartbeat, this activation of the atria, it actually happens in reverse.
Oh, wow.
It moves upwards from the AV node region, and this upward movement, it's often described as concentric or septal, meaning it starts in the central wall between the atria and spreads outwards and upwards in a kind of like a symmetrical fashion from the lower parts of the atria to the higher parts. You can think of it like, if you drop a pebble in a still pond, the ripples, they spread outwards in a circle, right?
Okay.
So in a lot of cases of AVNRT, the electrical activation of the atria, it kind of has the similar central starting point.
Okay, I see. So if we're looking at an EKG and someone's having AVNRT, what are we going to see that screams this could be AVNRT?
Well, one of the big clues on an EKG during AVNRT is something called a pseudo-R wave in V1.
Okay.
Now, lead V1, this is one of the views that we get on a standard 12-lead EKG. And it's basically looking at the heart's electrical activity from a very specific angle.
Okay.
And this pseudo-R wave, it's this small little positive deflection that appears right at the end of the QRS complex, or even slightly after it in that V1 lead.
Oh.
So it can be subtle, but it's a very important indicator because it basically reflects that backward activation of the atria that's happening very close to the AV node.
Gotcha.
You can almost think of it like as a little echo in the electrical signal that we can pick up on the EKG.
Huh, that's cool. And there's this phrase, dual AV nodal physiology. What in the world does that mean?
Okay, so imagine that the AV node, this is that crucial electrical gateway between the atria and the ventricles. Imagine it has not one, but two main pathways for electrical signals to travel through.
Oh, interesting.
Yeah, and these pathways, they're often called the fast pathway and the slow pathway.
Okay.
And the key difference between them is how quickly they conduct electrical impulses and how long they take to recover after conducting an impulse. We call that the refractory period. So people who are prone to AVNRT, they often have this dual AV nodal physiology. It means they have both of these pathways, the fast and the slow, and they're functional within their AV node. And this difference in their speeds and their recovery times, that's what can cause a reentrant circuit to form, which is the underlying cause of AVNRT.
So is the AV node absolutely essential for AVNRT to occur?
Yes, absolutely. The tachycardia that you see in AVNRT, it's what we call AV nodal dependent, that reentrant electrical circuit, the one that keeps that heartbeat going really fast.
Right.
It has to involve the AV node. Typically, what you see during the tachycardia is what we call a one-to-one relationship between the electrical activation of the atria and the ventricles. So for every beat in the upper chambers, there's a corresponding beat in the lower chambers, all because of this AV nodal circuit.
Okay.
So if the AV node were to be blocked, the AVNRT would typically stop.
Okay, that makes sense. So there's this thing called the shortest VA interval during tachycardia, and they're saying that it's less than 60 milliseconds in AVNRT. What is that, and why is that so important?
Okay, so that short VA interval, and that stands for the time between the electrical activation of the ventricles and the subsequent retrograde activation of the atria.
Okay.
That's a really important hallmark of AVNRT. And because this backward conduction to the atria in AVNRT, it happens so quickly and so close to and often within the AV node itself.
Okay.
This time interval is typically very brief, usually less than 60 milliseconds.
Yeah.
And this is a crucial measurement because it helps us to differentiate AVNRT from other types of supraventricular tachycardias where the retrograde activation of the atria might take a longer route,
Okay.
maybe involving more of the heart tissue that's outside the immediate area of the AV node. So think of it like this. It's the distance that a signal has to travel.
Okay.
And in AVNRT, that return trip back to the atria is very short.
Okay, that makes sense.
Yeah.
Now, the material talks about an echo phenomenon with a jump from the fast pathway effective refractory period to the slow pathway. Can you break that down for us?
Yeah, so this echo phenomenon, this is really the core of how AVNRT can even begin. So picture an electrical impulse arriving at the AV node.
Okay.
Now, if the fast pathway, it's still in its refractory period, it's like a phone that needs to recharge, can't conduct the impulse.
Right.
So what happens? The impulse has to go down the slower pathway.
Okay.
And because it's slower, there's a delay in activating the ventricles. And we see this on an electrogram as a longer AH interval. That's the time between atrial activation and his bundle activation.
Okay.
Now, while the impulse is slowly making its way down the slow pathway, that faster pathway, it's had time to recover.
Right.
It comes out of its refractory period. So if the timing is just right, when that impulse reaches the end of the slow pathway and starts to activate the ventricle, it can also sneak back up that now recovered fast pathway to the atria and create an echo. And that jump that you mentioned refers to that point where the conduction suddenly shifts from being mostly over the fast pathway to being mostly over the slow pathway because that fast pathway was temporarily blocked.
I see.
The material actually gives a specific example where the AH interval might suddenly increase from, say, 230 milliseconds to a much longer 450 milliseconds. And this significant increase, it indicates that that electrical impulse has had to take a detour down that slow pathway because the fast pathway was still recovering. And this delay, it gives that fast pathway the opportunity to be reactivated in a retrograde fashion, potentially starting that AVNRT.
So if I'm getting this right, the initial blockage of the fast pathway, the detour down the slow pathway, causing that longer AH interval, and then the fast pathway recovering, these are the key steps in kicking off an AVNRT episode.
Precisely. That initial inability of the fast pathway to conduct the resulting conduction down the slow pathway with that delay, and then that fast pathway regaining its excitability, those are the perfect conditions for the electrical impulse to loop back up and start that self-sustaining reentrant circuit within the AV node.
So once AVNRT is actually happening and it's sustained, what's the typical route that electrical impulse is taking in this continuous loop?
Okay, so in the most common form of sustained AVNRT, the electrical impulse travels down the slower pathway from the atria to the ventricles, and then it goes back up to the atria through the faster pathway.
Okay.
So this continuous cycle down the slow pathway, which we call DS, and up the fast pathway, or UF.
Okay.
And this creates that rapid, regular rhythm of both the atria and the ventricles that we see in AVNRT.
So the material mentions that AVNRT usually stops when you give a medication called adenosine.
Yeah.
Why is that?
Okay, so adenosine, this is a medication that has a temporary but very significant effect on the AV node. It essentially slows down or can even briefly block the conduction of electrical impulses through the AV node.
Uh-huh.
And since AVNRT is so reliant on the AV node being part of that reentrant circuit, it needs to be able to conduct downwards on one pathway and upwards on another.
Right.
If you block the AV node with adenosine, you're essentially interrupting that tachycardia's electrical loop.
Got it.
And that lets the heart rhythm return to its normal pace. And this response to adenosine, this is another really useful clue when you're trying to diagnose AVNRT.
That makes a lot of sense. Okay, that was a fantastic explanation of AVNRT. Now let's move on to atrioventricular reciprocating tachycardia, or AVRT. And the first thing that jumps out is this idea of accessory AV pathways, or APs. What are those?
Right. So these accessory pathways are basically extra abnormal electrical connections between the atria and the ventricles that exist outside of that normal, highly specialized AV node and his Purkinje system.
Huh, interesting.
You can think of them like having an extra wire in a house's electrical system.
Okay.
It's like a shortcut or an alternative route for the electrical impulse to travel between the upper and lower chambers of the heart. So normally, the AV node is the only electrical connection between the atria and the ventricles.
Right.
But in AVRT, this extra pathway creates the potential for a reentrant circuit that includes the atria, the ventricles, and this accessory connection.
So these accessory pathways, they're not all the same, are they?
No, they're not.
Because the material talks about concealed pathways and manifest
Yeah,
pathways. So
right.
what's the difference?
Okay, so concealed accessory pathways are pathways that can only conduct electrical impulses in the retrograde direction. That means from the ventricles back up to the atria.
Okay.
So during normal sinus rhythm, when the electrical impulse travels from the atria to the ventricles through the EV node, these concealed pathways, they don't participate in conducting downwards. So because of that, they don't cause what we call pre-excitation of the ventricles, and you won't see a delta wave on the baseline EKG during normal heart rhythm.
Got it.
Now, manifest pathways, these are different. They can conduct in the antegrade direction, meaning from the atria to the ventricles, as well as retrogradely.
Okay.
And when they conduct antegrade during sinus rhythm, they cause the ventricles to be activated earlier than they normally would be by the AV node and his Purkinje system. And this early activation, that's what produces that characteristic delta wave on the sinus rhythm ECG. It's a telltale sign that there's an accessory pathway present and that can conduct from the atria to the ventricles.
So how common are these accessory pathways in the overall scheme of SVTs?
So the material indicates that patients with accessory pathways account for about 30% of all supraventricular tachycardias.
Okay.
So they're definitely a significant portion of people who experience these rapid heart rhythms.
So what about the typical age? When do people typically start to notice AVRT?
So the history often shows that these tachycardias tend to start a little bit earlier in life, often in childhood or young adulthood. And this earlier onset, it can sometimes help us to differentiate AVRT from AVNRT, which usually presents a little later in life.
Okay, that's interesting. And is there a gender difference?
Yeah, unlike AVNRT, which we said is more common in females,
Right.
AVRT is actually observed to be more prevalent in males.
Okay. So similar to AVNRT, AVRT also involves retrograde atrial activation. Is the pattern of this backwards activation the same as in AVNRT?
Well, it can be similar. The atria might be activated in a concentric or septal pattern, moving from low to high. But where that accessory pathway is located, it can also influence this pattern.
Okay.
Because these pathways can be located in various places around the heart, not just within or near the AV node, the retrograde atrial activation in AVRT can also be eccentric.
Okay.
It means that it might start in a different area of the atria depending on where that specific accessory pathway is inserted.
Now this seems important. The material highlights that AVRT is dependent on both the AV node and the ventricles.
Yes.
So what are the implications of that?
Okay, so this is a key point. The reentrant circuit in AVRT, it needs a pathway to go from the atria to the ventricles, which can be either the AV node or the accessory pathway, and then a return pathway from the ventricles back to the atria, which is usually the other of the two.
Okay.
So the tachycardia can't continue if there's a block in either the AV node's ability to conduct or in the accessory pathway's ability to conduct retrogradely from the ventricles to the atria.
Uh-huh.
So both parts of the loop are essential for that rapid heartbeat to continue. If one part of the circuit is interrupted, the tachycardia will usually stop.
Okay, I get it. So there's this line about atrial preexcitation when his refractory proves AP. What does that mean?
Okay, so that's referring to a situation where the normal electrical system that conducts impulses to the ventricles, the His-Purkinje system,
Right.
it recovers more quickly than the accessory pathway. It has a shorter refractory period. So an electrical impulse that's coming from the atria might find that the accessory pathway is still recovering and therefore it can't conduct.
Uh-huh.
So that impulse would then travel down the normal AV node and His-Purkinje system to activate the ventricles.
Okay.
And in this case, you wouldn't see pre-excitation on the EKG because the ventricles are being activated normally first.
Okay.
But if that accessory pathway recovers quicker, then it can conduct the impulse to the ventricles earlier, and that leads to pre-excitation. So basically, the presence or absence of pre-excitation, it can depend on the relative recovery times of these two pathways.
Okay, that makes sense. So the VA interval during tachycardia in AVRT, how does it compare to the very short interval we saw in AVNRT?
All right, so this is another way that we can tell AVRT from AVNRT. In AVRT, that VA interval during tachycardia, it's usually greater than 60 milliseconds.
Oh.
And this longer interval, it makes sense when you consider that the electrical impulse it has to travel down to the ventricles, either through the AV node or the accessory pathway, and then travel all the way back up to the atria through that accessory pathway. So this route, going down through the ventricle and then all the way back up to the atrium, it's a much longer journey than that very short, almost direct retrograde conduction that happens within or right next to the AV node in AVNRT. So if you see a VA interval that's longer than 60 milliseconds, that strongly suggests that there is an accessory pathway involved, and that points towards AVRT.
So do accessory pathways conduct electricity in the same way as the AV node?
That's a good question. So the AV node, especially that slower pathway we talked about in AVNRT, it has this property called decremental conduction.
Uh-huh.
And what that means is that if the electrical impulses are arriving at the AV node really fast, the AV node is going to slow down their transmission to the ventricles.
Okay.
It's like a bottleneck that gets more congested with more traffic. Now, accessory pathways don't usually have this slowing property. They tend to conduct electrical impulses at a more consistent speed, regardless of how frequently the impulses are coming in.
Mm.
So this lack of decremental conduction in accessory pathways, it's another key difference from the AV node, and it really affects how these tachycardias involving these pathways behave.
Okay, so let's talk about the different ways AVRT can actually happen. There's antidromic AVRT and orthodromic AVRT. So what's the difference between the two?
So these terms describe the direction in which the electrical impulse is traveling around that reentrant circuit in AVRT.
Okay.
Orthodromic AVRT, this is by far the most common type. It accounts for like 90% of cases.
Okay.
And in orthodromic AVRT, the electrical impulse, it travels down the normal AV node and is Purkinje system to activate the ventricles. And this gives you a narrow QRS complex on the EKG because the ventricles are being activated in that normal coordinated way. And then the impulse travels back up to the atria through the accessory pathway. So the normal conduction system is used to go down and the accessory pathway is used to come back up.
Got it.
Now, antidromic AVRT is much less common. It's only about 10% of cases. And in this type, the impulse travels down the accessory pathway to activate the ventricles. And because the ventricles are being activated prematurely and not through that normal His-Purkinje system, this gives you a wide QRS complex on the EKG.
Right.
Showing that the depolarization of the ventricles is happening in an abnormal sequence, and then that impulse returns to the atria through the AV node.
Got it.
So in antidromic, it's the accessory pathway going down and the AV node coming back up. And that QRS width during the tachycardia, that's the biggest clue to tell which type it is.
Okay, that's a good way to remember it. So where are these accessory pathways typically located around the heart?
So these accessory pathways can be found in various spots around the rings of tissue called annuli that surround the mitral and tricuspid valves. Those are the valves that separate the atria from the ventricles. And the material specifically mentions septal pathways, which are located in the wall that separates the two atria to two ventricles.
Right.
And then there are free wall pathways, which are found along the outer walls of the ventricles, and then lateral pathways, which are specifically on the left or right side of the heart. So knowing where they can be located is important when you're thinking about how that electrical impulse might be traveling, and also for things like catheter ablation.
Okay, so the material has this algorithm for AP identification that uses the delta wave on the EKG for manifest accessory pathways.
Hmm.
So it seems like they're trying to use the EKG to figure out where that extra connection might be.
Exactly. For patients who have manifest accessory pathways, meaning that they have that delta wave on their sinus rhythm ECG, the shape and direction or polarity of that delta wave in different leads of the 12-lead EKG can give us really good clues about where that accessory pathway might be. It's almost like using the EKG as a non-invasive map to figure out where this extra electrical bridge is.
So let's go through some of those clues. So if the delta wave is positive in lead V1 of the EKG, what does that tell us?
Okay, so a positive delta wave in lead V1 often means that the accessory pathway is on the left side of the heart.
Okay, and what if the delta wave in V1 is negative?
A negative delta wave in V1 usually suggests that the pathway is on the right side of the heart.
Okay, what about the inferior leads on the EKG, leads 2, 3, and AVF? What if the delta wave is positive in those leads?
So a positive delta wave in the inferior leads often points towards an accessory pathway that's located in the anterior or the front part of the heart.
And if the delta wave is negative in those same inferior leads?
A negative delta wave in leads 2, 3, and AVF usually indicates a pathway that's in the posterior or back part of the heart.
Okay, what about a negative delta wave in lead 2 specifically?
A negative delta wave in lead 2 can suggest a couple of things. It might indicate that the accessory pathway is located in or near a vein called the coronary sinus, which runs along the back of the heart.
Uh-huh.
Or it could suggest a pathway that's epicardial, meaning it's located on the outer surface of the heart.
Okay, what about the lateral leads on the EKG, leads 1 and AVL? If we see a negative delta wave there, what did that mean?
A negative delta wave in the lateral leads often suggests an accessory pathway on the left lateral side of the heart.
Okay, and what if we see a change in the delta wave polarity between leads V1 and V2, where it's negative in V1 and then positive in V2?
So that transition from a negative delta wave in V1 to a positive one in V2 is a helpful clue that the accessory pathway might be located in the septal region, that wall between the ventricles.
So what if we don't see any of these patterns?
If the delta wave polarities don't fit into any of those patterns, it could mean that the person might have more than one accessory pathway.
Oh, wow.
It's not as common, but multiple pathways can happen.
So they say that we should be focusing on that first 25 milliseconds of the QRS complex.
Right.
Why is that initial part so important?
So that initial part of the QRS complex is where the effect of that early activation of the ventricles because of the accessory pathway, the pre-excitation, is most obvious.
Okay.
So before the normal electrical activation from the AV node and his Purkinje system has had a chance to really contribute to the overall shape of the QRS complex, that initial slurring, that delta wave, it mostly reflects the conduction over the accessory pathway. So by looking at that early part, we get the clearest picture of the pathway's electrical influence on the ventricles.
Let's talk about septal pathways and this technique called Para-Hisian pacing. What is that and what is it used for?
Okay, so Para-Hisian pacing is a special procedure that's done during an electrophysiology study. And it's meant to help us differentiate between retrograde conduction, meaning that backward flow of the electrical impulse from the ventricles to the atria.
Right.
That's happening either over a mid or anteroseptal accessory pathway versus retrograde conduction that's happening just through the AV node. And this is really helpful when the pattern of atrial activation that we see during tachycardia suggests that the origin is central or septal, which could either be due to an AV nodal pathway or a nearby accessory pathway.
Okay.
So basically, Para-Hisian pacing helps us to answer the question. When we see retrograde conduction to the atria, is it going back up through the AV node, or is it taking a shortcut through an accessory pathway that's close to the His bundle?
Okay, so how do they do Para-Hisian pacing?
So it's not just about where you put the pacing catheter, but it's also about how strong the electrical output is that we use for pacing. So the catheter is placed on the right ventricular septum in a specific area that's just below where we record the electrical activity of the His bundle. Uh-huh.
And just above where we might record the right bundle branch. And then we do two main things. First, we pace at a pretty high electrical output, and this higher output is strong enough to directly stimulate and capture the His bundle.
Okay.
And that gives you a narrow QRS complex on the EKG, just like normal activation of the ventricles.
Yeah.
And then second, we gradually reduce that pacing output until we lose that capture of the His bundle. And when we do that, the QRS complex becomes wider because now we're just stimulating the local muscle of the right ventricle in the septum, and the impulse spreads to the rest of the ventricles in a less coordinated way.
Okay.
So by looking at how the timing of the atrial activation changes, and specifically the SA interval, which is the time from the pacing stimulus to the activation of the atrium,
Okay.
and relating that to whether or not we're capturing the His bundle, which we know by looking at the SH interval, the time from the stimulus to the His bundle activation. And by looking at the QRS width, we can tell the difference between AV nodal and accessory pathway conduction. Okay, that makes sense. So let's think about it if there's no accessory pathway there.
Right.
What would we see when we go from that high output where we're capturing the His bundle to the low output where we're just doing local ventricular capture?
Okay, so if there's no accessory pathway involved, when we pace at a high output and we capture the His bundle, we'll see a shorter SH interval and a narrow QRS, and that electrical impulse travels down the His Purkinje system, activates the ventricles, and also travels retrogradely to the atria through the AV node. Now, when we lower the output and we lose His capture, we'll see a longer SH interval and a wider QRS, and now the ventricle is being activated from that local spot in the high septum.
Okay.
The impulse then has to spread through the ventricular muscle to reach the His Purkinje system, and only then can it travel retrogradely up to the atrium through the AV node. So this is a longer, more roundabout way to get back to the atria, and that means that the time it takes for the pacing stimulus to activate the atrium, the SA interval, is also going to increase. The material gives an example with retrograde conduction over the fast AV nodal pathway in AVNRT. When His capture is happening, the SH interval gets shorter, and this is matched by a similar shortening of the SA interval. And the way that the atria are activated stays the same. This tells us that the retrograde conduction is happening because the His bundle is being activated, so there's no accessory pathway involved. There's another example that shows retrograde conduction over the slow AV nodal pathway in AVNRT.
Yeah.
So here, losing His capture leads to a longer SH interval, and we see that reflected in a longer SA interval as well, again with no change in how the atria are activated. And this suggests retrograde conduction that's solely over the AV node, probably through the slow pathway in this case, especially if we also see that the electrical activity in the coronary sinus, which is another way to look at atrial activation, is happening earlier than the Fus bundle activity when we lose His capture.
So that all makes sense for when the retrograde conduction is happening through the AV node.
Right.
But what if there is an accessory pathway? What would we see with Para-Hisian pacing?
If there is an accessory pathway there and it's being used for retrograde conduction, the atria are going to be activated from the ventricles pretty rapidly and consistently, whether or not we're directly capturing the His bundle.
Okay.
And that's because the impulse can travel directly from the ventricles to the atria through the accessory pathway. It doesn't have to rely on the His Purkinje system for retrograde conduction. So in the example they give, when we lose His Purkinje capture, we get a wider QRS and a longer SH interval, but the SA interval won't really change, and the pattern of atrial activation stays the same.
Okay.
And this tells us that the retrograde conduction to the atrium is relying on the ventricle being activated, which then activates the accessory pathway, and not on the His bundle being activated and conducting retrogradely through the AV node.
So with Para-Hisian pacing, what are the key things we're looking for to tell us whether the retrograde conduction is through the AV node or through an accessory pathway?
The big things to remember are a wider QRS and a longer SH interval. That means we're only capturing the local ventricular muscle.
Okay.
But a narrower QRS and a shorter SH interval, that means we're also capturing the His and right bundle.
Right.
And if the SA interval, which is the time to atrial activation, changes in the same way as the SH interval, then it suggests that the retrograde conduction is happening through the AV node and is dependent on the His bundle being activated.
Okay.
But if we see consistently short SA intervals that don't really change, or they don't change when the SH interval and QRS width change, that's a strong sign that there's an accessory pathway involved in the retrograde conduction.
Okay, that makes sense.